Hi, this is Dr. Strife with Richmond Vascular Center, and I wanted to do another segment on adenomyosis because lately I've been treating a number of women with adenomyosis as the primary driver of their symptoms or concomitant fibroid disease and adenomyosis. And this is something I talked about in previous posts, is that what I'm finding in clinical practice is that although transvaginal ultrasound and MRI are both very good at the diagnosis of adenomyosis using modern criteria, what we see is that many women, despite having those tests done, still don't get the diagnosis appropriately described in the report. And this can become a big problem when you are trying to decide on what is explaining your patient's symptoms, meaning you're trying to diagnose your patient with a condition, and you're only as good as the information or data in front of you. And if you're not an expert in the imaging modality that is being performed and you can't review the images yourself, well, then you're stuck with somebody else's interpretation. I am an expert in radiology. I have more expertise in reading MRI than I do transvaginal ultrasound, but I try to review all the images whenever I can. But many of the women that I see have either a transabdominal and or transvaginal ultrasound. The ultrasound does not necessarily identify that. And even when I obtain an MRI, as we frequently do prior to offering uterine artery embolization as a treatment for fibroids or adenomyosis, what I'm finding is that the diagnosis is not made even on MRI. And I'm going to show you this patient here now who had multiple uterine fibroids on ultrasound. Adenomyosis was not identified on the ultrasound report. I did not get to review the images myself. I ordered the MRI, and the interpretation came back as multiple fibroids, even though there was flagrant adenomyosis on this study. Of the uterus, this is sort of the midline look. Here's the thin endometrium. And what we should normally see is the zonal anatomy of the uterus, meaning we should see what's called the junctional zone or inner myometrium, and then the outer myometrium, and then of course the serosal surface. But what we see here really is loss of the normal zonal anatomy of the uterus, and that's because this patient has diffuse adenomyosis. And I would say this patient has really, really classic appearing adenomyosis on MRI. What we see here is significant thickening of the junctional zone out to over 2 centimeters. We can start to see sort of the edge of it here, and then this would be the outer myometrium. But really diffuse thickening of this entire area of the uterus where the junctional zone or inner myometrium is well beyond 12 millimeters. And in addition, there are innumerable T2 hyperintense foci within that abnormal thickened junctional zone. This is absolutely classic for diffuse adenomyosis. And then of course we have, an intramural fibroid, 2 large fibroids here. And when I see this patient who has multiple fibroids, prolonged heavy bleeding, severe cramping, and the MRI shows, 15 fibroids, all the different types, submucosal, intramural, subserosal, but on top of it, there's really significant diffuse adenomyosis. And then we're talking about, we're offering uterine artery embolization for treatment. You might say, well, who cares? What does it matter? Well, it does matter. It matters because we want to be accurate in our interpretation. We want to counsel patients appropriately when we're offering particularly invasive treatments to them. And then if the patient doesn't do well, it might be an explanation as to why the pathology did not respond to the treatment appropriately. As I talked about previously, fibroid disease, when we use uterine artery embolization, the symptom improvement is typically on the order of 80 to 90% for bleeding and bulk symptoms. With adenomyosis, we need to lower those expectations, particularly in cases of significant diffuse adenomyosis. We can say that, this component of the disease is probably going to respond on the order of 75% initially, and then that's going to diminish over time. So if I have a woman in her mid-40s doing a UAE in this scenario for numerous fibroids and significant adenomyosis, this will likely be the last treatment that this patient needs. However, if this is a younger patient, say 40 years of age or 35 years of age, it's going to be a different conversation. So how you counsel a patient, particularly when we're talking about fibroid disease and adenomyosis in the context of uterine artery embolization as a treatment, really understanding the pathology, the different treatment responses, and what is the actual diagnosis and what is driving the symptoms in your patient is absolutely critical to what I consider good medical care.